We're going to get started. We are about to get started. Thank you guys so much for being here and being on time and being interested in this issue. And I am going to share my screen. So welcome. Today we're here talking about anti-criminalization for public health departments and really for public health broadly. We're really excited about having this conversation today and really thrilled that you're here to have it with us. Sorry. And so today, first and foremost, we're going to just do a quick introduction of the space, and then we're going to talk just briefly about what anti-criminalization for public health actually is, and then switch over to two really amazing panelists that I know I'm really thrilled to see in conversation on this, who are truly incredible experts on this topic. And then at the end, we will open it up to Q&A for the audience. And just some quick housekeeping in the meantime. We're asking everyone to turn off your videos and please set your microphones to mute in order to reduce the background noise and also save the bandwidth for folks that also have 1,500 Google Doc tabs open and need to figure out how to prioritize. Second, we're going to ask everyone to keep the Q&A in the chat for the duration of the conversation. And then once we move to Q&A, if you feel more comfortable, raising your hand and asking it verbally, absolutely. But for the meantime, we're just asking if you do have questions, place them in the chat and we will try to monitor those. Next, we're going to ask everyone to just be open to learning and growing, including us. All of us are on a different journey and all of us are on our own learning curves. And so we welcome everyone who is open to moving along in that conversation and being open to what's shared here. And then finally, we are going to be recording this presentation, which means if there's things on the screen or things that are verbal, those will be recorded. The chat does not get recorded in that. And so if you do have any questions or anything about that, please DM one of us and we can try to answer that if you have any concerns. Before we go any further, I want to ask our colleagues from NASTAD to tell us a little bit about what brought this conversation forward and why NASTAD thought it was an important conversation to have.
Thank you so much, Kate. And hi, everyone. Welcome to our Anti-Criminalization for Public Health Systems webinar today. My name is Alika Upadhyay, and I am a senior associate on the Drug User Health team here at NASTAD. Thank you all for being here, and extra thanks to Reframe Health and Justice, who've been working on this resource and this webinar. And so NASTAD has been working with Reframe through the National Harm Reduction and Technical Assistance Center to develop these resources specific to serving and providing harm reduction services for people who are criminalized, who have been involved with the criminal justice system, including people who trade sex and people who use drugs. The goals for this webinar today are to discuss how criminalization affects health and health equity, explain why public health agencies need to incorporate an anti-criminalization approach, and start to become familiar with some strategies that can be implemented by health departments and their community partners. And for decades, NASTAD has been a national leader in the fight to address HIV criminalization, laws, policies, and practices that unjustly sanction people living with HIV/AIDS by criminalization exposure and transmission, and recognizing that these laws are stigmatizing, discriminatory, ineffective, and serve as barriers to testing, prevention, and treatment goals. And beyond HIV, we recognize the criminalization of and punitive approaches to behaviors such as drug use and sex work, and wanted to make space to examine the different ways criminalization manifests in our public health work. Additionally, we know that racial and ethnic minority groups such as Black, Latinx, and Indigenous communities face increased criminalization due to systemic biases in policing and incarceration, and have been disproportionately impacted by the war on drugs. And we know that there's limitations for health departments in advocating for legislative and policy change, and we want to name that on the onset of this conversation. However, it's our hope to be able to provide a space for dialogue, facilitate partnerships between community grassroots organizations and governmental public health, as well as create opportunities for peer-to-peer sharing of successful or promising strategies, which can be influenced by public health agencies and professionals. So thank you guys again. Kate went through some of that housekeeping stuff, so I'm going to pass it back over to her.
Thanks so much, Alika, and thanks so much for foregrounding this conversation. Before we go any further, to introduce myself, I'm going to be your facilitator and sharing some of the initial information for today's conversation. My name is Kate Diadamo. I use they and she pronouns, and I'm with Reframe Health and Justice. We are a queer and trans people of color consulting organization that works at the intersection of harm reduction, healing justice, and criminal legal reform. For a lot of that means that we very often work with folks that are engaged in some form of criminalized survival, predominantly people that use drugs and people that trade sex. My background is community organizing, and so rooting our work also in community is a mainstay of what we do. And we are really honored to be able to work with NASTAD on this and with our amazing community partners, two of which are our panelists here today, to develop some of these resources. So thank you so much for being here. So first off, we just want to ground the conversation in what is anti-criminalization and why does it matter for public health departments in particular, but for public health broadly, to really understand this issue and understand the relationship between health and criminalization. So as we move into criminalization, we want to, or anti-criminalization, let's start by talking about what criminalization is. Criminalization broadly takes on a lot of different forms, but let's ground it in a more conceptual space. Criminalization is the process of turning actions into crimes and the process of turning people into criminals. And what that means is that anytime we're talking about criminalization, what we're talking about is social penalty as enforced by state actors. And so that means that ultimately what we're talking about is a range of actions. And if we're going to talk about them neutrally, that might be the best place to start, especially when we're talking about the impact on health. And so, these might be actions that are considered things that we do want to socially sanction. We want to maybe sanction something like theft or injury to another person, physical harm. But it is broader than that. And so especially when we're talking about things like substance use, things like possession, it really is a sanctioning of actions that face penalties. And what it means when turning people into criminals is that when people participate in those actions, they show up in a different way in relationship to the state and therefore to state actors. And so all of a sudden, it is not only impactful to people's behavior, but it also is impactful to their identity and how they are treated by society. And that's really important when we think about the ways that people are especially able to access care and services that might be negotiated through state-based actors such as health departments. When we talk about criminalization, we also should really be talking about the actors of criminalization, because this can look a lot of different ways. Very often, we are talking about police departments, frontline law enforcement, cops, essentially. But it is broader than that when we're thinking about criminalization as this full-length process. And so when we're talking about criminalization, yes, we are talking about police and law enforcement, but we're also talking about courts, including things like drug courts or diversion programs. We're talking about spaces of jails and prisons and people that work inside them, such as the Department of Corrections. We're also talking about immigration detention centers. So even in situations where these might be criminal legal proceedings or civil proceedings, this is still really impactful. Similarly, juvenile detention centers. And another space that is not necessarily talked about, but especially when we're talking about not just people, but communities and people who are connected to families as experiencing criminalization, the family regulation system, which is known as child welfare, family welfare, child and family services, depending on the state, is also a space of criminalization. And especially for people who are caregivers who use substances, this can put you in a system, non-consensually put you in a system where you are experiencing penalization for those behaviors. And when we're looking at not just the legal system, but the penumbra of actors around the legal system, we should also be including court-mandated services programs, including drug treatment programs, where someone is forced to participate in a treatment program. And if they either don't complete the program or drop out, they would face some kind of sanction. So they're still required. It is still a punitive process, even if the process is taking place in something that is ostensibly considered a health program. It still is an experience of criminalization. And so when we're looking at the impact of these broad pieces, criminalization is not just a set of laws, it is not just a set of actors, but is actually a much broader life cycle of actions. And so a lot of times we're talking about criminalization and people's mind goes to, all right, when you are booked and serve time. It is that specific experience that is what we often are focused on. But criminalization begins long before someone ever encounters the legal system directly, and definitely before someone might be incarcerated. And the ramifications of criminalization exist long after a person has gone through that system. And this is just a super brief piece that's going to talk about some concrete ways that criminalization impacts public health, but please do not consider this an exhaustive list. I have no doubt that almost every single person on this call could probably name 1,000 more things of the way that criminalization can impact someone's health and well-being. So first and foremost, when we're talking about policing and surveillance, that's really the first step of criminalization. If you're engaged in something where you know you are actively being policed, your behavior is going to change in order to avoid that experience of policing, arrest, and incarceration. And so even long before someone physically encounters a law enforcement officer, you're probably doing things that might be impactful to your health. And so, for example, if you're talking about someone who might be using in a public space or even a semi-public space, they might say, all right, I don't want anyone to see me, definitely not a law enforcement officer. And so I'm going to use faster to be able to get somewhere else or just complete that process before someone sees me. They might also say, I don't know who's around me and I don't know who to trust. And so I would rather be in an isolated location to use. And both of those we know are directly impactful to someone's experience of overdose. If you use too fast, if you use in a place where something happens and you can't call for help, both of those things are going to negatively impact someone's health. And the next stage is what we often think about. It is those encounters with law enforcement, the arrest, the booking, being in overnight waiting to be arraigned the next morning or probably a few days later. And in that moment, there's also impacts on someone's health. So if you are arrested and you don't have medications on you, they check you and take substances, you might be experiencing withdrawal while you're before you're booked in a holding cell, not having access to medications. If you're on something where you have to take regular medication, it really interrupts people's continuum of care and negatively impacts folks that way. Afterwards, if we're talking especially about a longer sentence, or even when someone's in overnight, experiences of violence are rampant throughout our prison and jail systems. And access to care is very, very difficult, especially when it happens in relationship to those experiences of violence. And so the harm that directly impacts people when they are incarcerated is absolutely immense. And then finally, upon reentry, we know there are rampant problems with people lacking access to connections to care, including getting kicked off of Medicaid and having to go back on, as well as having a conviction on your record can create incredible barriers to things that we know are impactful to people's health. Having access to housing vouchers doesn't happen when you have a number of different charges and police records. Having access to SNAP benefits can also be taken away. And so the long-term impacts of criminalization in a person's life are incredibly significant, especially when we're talking about long-term health outcomes that are compounding on each other after all of this as folks go through. And it's important to remember that this is a cycle. For people upon reentry, you're still going to be dealing with parole and probation, and depending on where you are, that can be an incredibly long time where the slightest slip up can land you back in this cycle of arrest, incarceration, reentry, parole, and then rearrest. And I'm only going to take a couple minutes. There's some incredible resources that talk about the history of public health systems and law enforcement. I really, encourage reading some of those pieces, and I'll throw one or two links in the chat after this. But as brief as I possibly can be, the history of law enforcement and of public health systems definitely go hand in hand. There are many historical examples where public health systems have relied on law enforcement in order to do that kind of surveillance and control work, whether we're looking at things like the use of law enforcement to police, especially people in the sex trade or women presumed to be in the sex trade, in order to forcibly test them for STIs and then forcibly treat them while being held. It's those kind of interactions between these systems and law enforcement chart very much the same course, whereas public health systems have been increasingly developed, law enforcement systems have been part and parcel to an expansion of that surveillance and treatment. Also, criminalization has historically showed up as we've talked about structural determinants of health. In looking at the last several decades of understanding structural determinants of health, policing and criminalization has taken a much more prominent role in understanding, especially when we look at racial and race equity in health outcomes as a determinant of folks' well-being and of understanding some of those gaps. As we have increasingly policed and criminalized different communities through the war on drugs in particular, we see the impact on health create significant racial disparities between racial and ethnic groups. In the last several years in particular, public health systems have really started to begin to understand criminalization and policing as a health crisis, especially after the wave of recognition. I'm not going to necessarily call it a wave of police violence because it was a continual experience. The change was not necessarily the experience of police violence on Black communities. The change was a recognition and a lifting of those stories in mainstream media. And through experience, national stories such as George Floyd and Sandra Bland, we have been able to really see the impact of policing and criminalization on people's health and on specific communities in particular. And after that, a number of health departments and cities grounded in health equity have started to increase the way that they are talking about and going after health equity and including anti-criminalization efforts in that work. And so that takes us to what is anti-criminalization. And the definition that we have been using comes from the American Public Health Association, who in 2021 recommended moving towards the abolition of carceral systems and building instead just and equitable structures that advance public health by reducing the incarcerated population. This was something that especially came to the forefront when we were talking about COVID, and we really understood the ways that jails and prisons were an important part of controlling the spread of the COVID virus, not just talking about people in those facilities not being able to protect themselves, but folks that worked in those facilities not being able to stay safe, and then leaving the facility to go back into the community, as well as even looking at people who were just cycling through and not being incarcerated, were just going in for booking. It was still a public health emergency that was fueled by criminalization. Next is divesting from carceral systems and investing in the social determinants of health. We know that budgets can feel like a zero-sum game on the city and county level. And so this is about really recognizing that the funding that we put into carceral systems is funding that really needs to be invested in communities and in supports for people's health and well-being. A commitment to non-carceral measures for accountability, safety, and well-being. If we are measuring our public safety in criminalization practices, then we really have to think about what we mean when we are talking about public safety and well-being. Restoring voting rights to formerly and currently incarcerated people, making sure if we're talking about criminalization as the process of turning people into criminals, this is about making sure that people still have access to the rights of being a citizen and still have access to that dignity. And finally, funding research to evaluate policy determinants of exposure to the carceral system and proposed alternatives. There's been a lot of research on the connection and seeing that there is a correlation between health and criminalization. We need to better understand that, and we need to take that one step further to actually talk about evaluating policies and thinking about alternatives to these systems of criminalization and carcerality, and thinking about what that would mean for people's health and well-being and how those two things are intimately tied together. We've established the correlation between the two of them. Now we need to understand the why more, and we need to understand a little more about what's next. And so before we turn it over to our incredible panelists, I think it's really important to also ground in an understanding of why public health specifically needs to take on anti-criminalization as a part of doing not just health work, but health equity work. And first and foremost, it is one of the structural determinants of health. If we're going to take those seriously as impactful to our outcomes, this has to be a part of that dialogue. I think secondly, and for me, one of the things that's most important and most pressing to this conversation is that policing and surveillance is continually expanding. There's a lot of ways that we can see in especially our modern systems, as we're all moving online, as the ways that we participate in society are shifting. What is also shifting is the ways that policing and surveillance is happening. And the relationship between public health and policing has always been there, but the longer that we wait to untangle these two, the harder it will be. As policing expands and as more spaces of health and well-being are tied into these spaces, it's going to be increasingly difficult. And so taking this on and understanding that it is a pressing problem that needs immediate attention means doing work now that we won't have to undo later, as these two systems increasingly grow together. And we saw that through COVID. We see that in the ways that we talk about anti-violence approaches, where law enforcement systems and medical systems are unfortunately painfully intertwined. And so with that, I'm going to stop sharing my screen and switch over to our really amazing panelists. We're so excited to have this conversation and to bring these folks into dialogue together. So I'm going to start by introducing our two panelists. Amber Akambipia is the Health Instead of Punishment Program Director at Human Impact Partners, a national nonprofit organization focused on transforming the field of public health to center equity and building collective power with social justice movements. Her work advances health equity, racial justice, and public safety by shifting away from criminalization, incarceration, and surveillance and toward community-led solutions. She completed her Master's of Public Health from the University of California, Berkeley, and a Bachelor's of Arts in Psych and Spanish from the University of California, Los Angeles. And thank you so much, Amber, for being with us today. And second, I'm going to introduce Jules Netherland, who is the Managing Director of the Department of Research and Academic Engagement for the Drug Policy Alliance. In that role, she advances drug policy reform by supporting scholars in doing advocacy, convening experts from a range of disciplines to inform the field, and strengthening DPA's use of research and scholarship in developing and advancing its policy platforms. Dr. Netherland previously served as the Deputy State Director of DPA's New York Policy Office, where she was instrumental in passing 2 laws to legalize the use of medical marijuana in New York and advancing a number of harm reduction and public health approaches to drug policy. She is also the co-author of Whiteout: How Racial Capitalism Changed the Color of Opioids in America, which is being released next week. Thank you both so much for being with us. We really appreciate you being here to have this conversation.
Thanks, Kate.
And our first question, I'm going to turn it over to both of you. And Amber, if you could share with us first. We'd love to hear just more about your work and specifically how criminalization shows up in what you do. And I would love it if you could give us just one takeaway, just right at the outset, that you came here to share.
Yeah, thank you so much for having me. And I'm just excited to be here and talk with you both. I'm always so happy to be in conversation with Jules in particular. So I work at a national public health organization, Human Impact Partners, where I lead our health instead of punishment program. And that program's work is really all about criminalization, policing, incarceration, and looking at the public health impacts of these issues and looking at the public health evidence that really supports using community-led solutions that don't rely on carceral systems and actors. So we're a pretty small team, and that allows for us to really be specific and narrow about some of our key priorities. So happy to talk more about what those are in more detail, but lately some of the work that we've been doing rooted in our research partnerships has been around trying to end ICE transfers, which is a system of double punishment toward immigrants that transfers folks coming out of jail or prison into ICE detention. And, this is actually the main pipeline into ICE detention. And if these folks had been citizens, they would get to go home to their communities, but instead they're being funneled into ICE detention and into deportation proceedings. This is a project that cuts across political spectrums, including Democrats who talk about wanting to deport felons, not families, and is a really just important issue to tackle. So that's been a big area of focus for us. And I'll drop a link to some of our research there if you're interested in learning more about that in a sort of text way. We've been working on federal policy, including supporting the Movement for Black Lives to try to pass the People's Response Act to build non-carceral emergency response systems, recognizing that people need emergency response and don't want to have to call the police to be able to access support in an urgent way. And other work, including supporting building up the next generation and supporting the next generation of abolitionist public health workers through our abolitionist public health student network. So excited to share more about any or all of that. But just as far as the takeaway, I think one thing that I really believe and try to sincerely impress upon people is that everyone has a role in this work, right? This doesn't need to be anti-criminalization work does not need to be your full-time job in order for you to be showing up and supporting this, right? There are different amounts of capacity and different seasons of capacity. And I think for me, it's really important that people get honest with themselves about what they have interest and capacity to do, and then really commit to that and be accountable to the partners that they're working with on that, and sort of stick with it for the long haul. I would much rather have someone who's doing 2 hours a month of anti-criminalization work, but reliably, than have someone who's all in for 2 weeks and signs up for all kinds of things and then realizes oops, I overcommitted and needs to back out, right? So I think figuring out what's actually sustainable and real and feels good is really important.
That's such a great takeaway, I think, for this and definitely for so many areas. And I love that you've already connected it to ICE and detention and how, criminalization looks and shows up in so many different ways. So thank you for starting us off on that nuance. And Jules, tell us a little bit about your work and the way that criminalization shows up.
Well, first of all, thanks for having me, Kate, and Amber. Always a delight to share time with you. So I work for the Drug Policy Alliance, which is a national organization working to end the war on drugs. And I won't go into much detail about what we do, but we are working on the decriminalization of personal possession of drugs, overdose prevention centers. And one of the things we're working on that I want to talk about a little bit more today is the way the war on drugs has infiltrated and in some ways captured a lot of civil systems and social services that are meant to help people. And so I think my one takeaway, which is much less practical than Amber's, is that the drug war and the criminalization of people who use drugs really extends far beyond the criminal legal system, and it's really infiltrated the very systems and services that are meant to help people. So instead of helping them, it's actually harming them. And then Kate, do you want me to go into some more detail about the way criminalization is showing up? Is that
Yeah, I'd love to hear about how it's manifesting in your work.
Okay. So Kate did a really great job of laying a lot of this out. So we know that arrests and convictions saddle people with lifelong barriers to service and care. But criminalization is not just about the collateral consequences of arrests and convictions, but also about the ways we police and punish people who use drugs across civil systems. And so I want to introduce this idea of what we started to call drug war logic. And that's a way of thinking or a logic that prioritizes and justifies drug prohibition, criminalization, and punishment, purportedly to address the real or perceived health harms of drug use, but prioritizing that over a public health approach to address these issues. So it's a logic that wants to punish individual people who use drugs rather than looking at structural and systemic issues that cause harm. And so there are a lot of actors where drug law in the settings where drug war logic is embedded, including physicians and healthcare providers, many who are very well intentioned, but unaware of how they may be perpetuating this logic through their actions, but also through the policy and practice of the institutions in which they're working. So I'm going to give just a couple of quick examples. So according to, sort of what I would call a rational drug war logic, people who use drugs are widely perceived as criminals, as failures, as morally deviant, as not deserving care or safety or support. But in reality, it's our systems that are failing people who use drugs. And so we see drug war tactics like drug testing, mandatory reporting requirements, bans on services and resources that are vital to people's health and wellness, cutting across all kinds of civil systems like housing, education, healthcare, immigration, public benefits. And so let me just give two quick examples. So drug war logic in the healthcare setting says people who use drugs can't be trusted, they're drug seeking, and therefore they need constant monitoring. It also says that drug use is a primary marker somehow of being unhealthy or in need of intervention, that if you're someone who uses drugs, that is antithetical to a healthy way of life. But in reality, what we know is that people who use drugs can be discouraged from engaging with systems that have discriminated against them and stigmatized them in the past. Their symptoms can be disbelieved, which can lead them to be disengaged or not seeking healthcare, or certainly very mistrustful of those systems. And so the mechanisms through which this works include things like drug testing as a primary mechanism of surveillance in healthcare settings, and the recording of a positive test coupled with the sharing of medical records. So for example, medical records that include drug test results can be accessed by a wide variety of actors in the medical system, subpoenaed for court, and used in future medical decision-making without the patient's knowledge or consent. We also know that this is especially a problem for pregnant people who are often tested without their knowledge or consent. So that's just a little bit of how it's showing up in the healthcare system. And then just one more quick example. Kate, you talked about the family regulation or child welfare system. And what a drug war logic says in that setting is that according to a drug war logic, right, any drug use, even suspected drug use, is automatically equivalent to child abuse, regardless of context or actual harm to a child. The underlying assumptions are, right, that parental drug use automatically harms children, that parents who use drugs cannot be good parents, that the foster care system can provide better care for children than families can, and that it's better to remove children from their parents than provide support or to improve the social and economic circumstances for families. But in reality, what we know, right, is that separating children from their parents leads to some of the very harms from which these policies purport to protect families. Removing children from parental care is associated with long-term mental and physical health problems and lower educational attainment, for instance, right? And then placing the blame on individual parents and drugs offers an easy scapegoat, right, that detracts us from focusing on the structural issues like racism, poverty, and lack of supportive services. In fact, what we know is that research shows poverty, right, is one of the largest predictors of adverse infant and child health outcomes. So how is this working? Through mechanisms like mandated reporting. We know that healthcare professionals, social workers, school teachers, counselors, mental health care providers are all required to report any suspicion of child maltreatment or neglect, which then often initiates a family regulation system investigation. So, and with drug testing, a child can be removed from their home if the caregiver tests positive for drugs, even absent any other evidence of mistreatment or abuse. And as I mentioned before, the drug testing of pregnant people, often without their consent, automatically triggers investigations. And so we know that, first of all, the racial disparities inherent in these kinds of strategies are horrific. We know that people of all races use drugs at similar rates, and that low-income Black and Brown parents are not mistreating their children at higher rates, but they are more likely to be targeted by these systems of surveillance. We're not looking at the drug use of white affluent parents by and large. In fact, the New York Times even published an article about how marijuana enhances parenting, clearly oblivious to how claims of marijuana use by poor parents of color can trigger these devastating investigations and family separation. So I'm gonna stop there because I don't want to take too much time, but I just wanted to give a few examples of how this drug war logic has perverted helping systems, making them harmful. And I'm going to drop a link to a article that me and my colleagues wrote in the Annals of Medicine that really fleshes out how this logic is working across multiple service systems.
Thank you so much for grounding us in that. And I think the language that you provided, drug war logic, is what we're fighting, is so helpful in thinking about how, you know, anti-criminalization is not just specific, like small interventions. It's really, it's a personal change. It's an internal change in thinking about our logic. It's an interpersonal way that we relate to each other. It's an institutional change in how our organizations act. And it's a systemic change for how to make sure that we're thinking about the relationship between criminalization and health, and between health outcomes and punitive interventions. So I love how you've shaped that as a really holistic approach to this conversation, and that really shares with us that about how, you know, we as different kinds of practitioners have to be invested in this kind of work. And it really is, you know, multi-stakeholder is a kind and diplomatic way of talking about how this really does require all of us. And Amber, I would love to hear more about the work that you're doing with community groups and with public health organizations. And I'd love you to talk a little bit about how they're different, but also how they can really be mutually reinforcing.
Yeah, I found myself so lost in thought, like, Jules, so much of what you're saying is so resonant. And maybe first, just to say a thread of thought I found myself on was thinking about like my own journey toward adopting and sort of practicing an abolitionist politic, and the fact that I came to this work through work around gender-based violence prevention and intervention, and the work I was doing 13 years ago with a respected nonprofit in Los Angeles that does this sort of work, and that has and promotes the fact that they have a partnership with LAPD, and myself going into schools and sort of preaching this about reporting to police adolescent dating abuse, and how much shame, as I started to understand, and having, you know, not because I had the privilege as a light-skinned East Asian woman of not being targeted by the police and not having a particularly adversarial relationship with police officers when I was younger, coming to understand the inherent and intentional anti-Blackness, colonialism, xenophobia, transphobia, classism, etc. of policing, and how painful and shameful it was for me to understand that I was going into LA public schools promoting police as a viable solution to young people, and how much years of my journey were about sort of understanding and in sort of transforming the sort of shame I felt about my earlier work. And so I think a thing I've been thinking a lot about is, as we try to move further along for us at HIP and for myself, so much of my work is about trying to move folks into more of an abolitionist ethic, how we will hold the fact that we want people to transition from being collaborative with police, and what shame might come up in that, and what room for growth will be necessary in that process. albeit sometimes next to space for accountability. So that's just something I've been thinking about and relates in some ways to the work that we do with public health organizations at HIP. But I'll start by saying the bulk of my time personally is spent working with community groups and mostly with community organizers. Our theory of change at HIP really emphasizes that we think that community organizers are huge builders and brokers of power in trying to in structural change, working directly with bases of people who are directly impacted by issues and working to build collective power to be able to affect policy change, cultural change, et cetera. And so at HIP organizationally, we have a dual mission. Part of our mission is around transforming the field of public health to center equity. And that's really, these aren't so discrete in our mission, but that's largely where our work with public health organization lives. And then the second part of our mission is to build collective power with social justice movements. And we have a new program that's really about the and between those two parts of our mission, trying to bridge across these two spaces that often use different languages, but in our view have similar sort of North Star goals and visions that we're trying to move toward. And so we orient different to different partners. We are much more deferential in a sort of supportive position when we're working with community organizers, recognizing that people who are closest to the problems are also closest to the solutions, and that our work is to also support in the work of getting them closest to the power. And versus in our work with public health organizations, which largely is governmental public health, we work a lot with state health departments, local health departments, and the associations and sort of regional groups, et cetera, that work with them. And in that space, we're much more willing to sort of lead and say, like, this is our perspective. This is what we think needs to happen, and come to that in more of a leadership dynamic. And so, across these, we do research, we do advocacy and organizing, we do capacity building and technical assistance. And I think as far as, so they're different in orientation and approach. They're different in sort of what the processes and what sort of outcomes we're moving toward, be it a policy campaign or a shift in internal norms within a health department. And I think for now, the reinforcing element is frankly aspirational. We do have some sort of projects that have been successful and reasons to be hopeful for that. But I think really, especially working with organizers who are presenting radical visions for shifting how we understand safety and accountability, understanding how we understand housing, we're moving into more work around the decommodification of housing, et cetera. These things are intentionally big and bold. And so I think for those who are working inside of the state, it can be tricky to understand how these can be reinforcing, but we're hopeful, and it's a big part of what we're thinking about and working on right now.
That's really, it's really interesting to hear how you really kind of navigate these things in two different spaces. And I love the intentionality that you bring to differently situated folks. When we're talking about race equity or health equity, one of the pillars that I think gets lost so often is about that redistribution of power. I think people sometimes don't realize, and even just the way that you're talking about it, about the deferential way that you approach communities and the directive way that you approach public health departments, I think really illustrates what that looks like in practice. And Jules, I would love to hear more. How do you see the role of research and academia in doing this work? And I think there's some folks in the chat that have asked questions about what advocacy kind of looks like with different actors. And so I'm really curious how you think about that. And also, how do you approach that to make sure you are building with and being led by community partners?
Oh, thanks for the question, Kate. I've had a long interest in my career in this sort of the tension between academia and research and policy and organizing. Someone who was trained in academia but works squarely within an advocacy organization. And so a lot of the work that my team and I do is about working with researchers and academics around how they can ensure that their work has real policy impact, but also that they themselves can be important actors in promoting policy change. And so generally academics, right, are not really taught how to do policy advocacy. But they can and should be playing really vital roles in shaping policy, whether that's through becoming resources to their local elected officials or testifying at hearings or lobbying for the kinds of changes we want to see. And so one key element about that has to do with, learning those skills. And my office has a lot of webinars and workshops on how to do that. But the other is about research translation. And frankly, this may be controversial, maybe not, but really the failure of the peer-reviewed journal process, right? Which is, frankly, very few people read those articles. And so it's getting academics to recognize that and learn how to write for the public and policymakers, and using, avenues like op-eds and fact sheets, and working with advocacy organizations to produce the materials that they can use in their organizing and lobbying efforts. But there's a real caveat, and a really important one, that researchers need to be doing all of this and their research in very close collaboration with community and the people most impacted by the policies they seek to change. Because, and I think Amber alluded to this as well, nothing makes worse policy, and I would say, or research, than that is shaped by people who are very far removed from the problems they're trying to address. And so there's a lot of great work being done now on community-driven research. And there's also a lot of, frankly, lip service paid to this idea of community engagement or, community-based participatory research that some of which is more or less effective, but often which is really tokenizing and, puts people on a community advisory board, but doesn't really let them participate fully or drive the research. So there are a host of sort of best practices and recommendations for how you do that. And it can be very challenging because academic institutions and the ways that a lot of academic research is funded, especially if you're talking about NIDA funding, although I think NIDA is increasingly open to new models, doesn't really support this kind of work. And by that, I mean like the kind of work where community folks, right, people directly impacted, people who use drugs, are making the decisions about the research questions themselves. Like not just coming in at the tail end, not just coming in after you've already written your specific aims, but like actually are getting to formulate the questions that matter to them in their community. So we just did a 4-part webinar series on community-driven research for people working in the field of drug policy research. And I'll drop a link to that, but there are lots of good resources out there. So I can go to more detail later if people have questions, but what I would say is please be working in close contact with community and really being willing to share power, and let folks make decisions about the kinds of things that are important to them.
Thank you for mentioning that, and thank you for naming that as not only important as an ethical concern, but also as really important to the research itself and to the quality of research itself. I remember when I was a community organizer, how often we'd get researchers to come in and then find out that we'd contributed hours to something that was now behind a paywall, and that once we found someone who was in school and would download the article for us, no one wanted to read the 57-page article. So I really appreciate you naming that responsibility of translation to invest in community, because community, if you're a researcher, community is investing in you by granting access. And so you have to give back. And I love that you named that.
Thanks. I just want to, sorry, one other quick thing about that is we often make the assumption that researchers are somehow different from the people they research, and that's often true. But it's also true that there are a lot of people who use drugs who are also researchers. And so that sometimes is a false dichotomy. But anyway, I just want to mention that.
No, I think that's a really fantastic point. And I think that kind of artificial psychic distance can really present a lot of challenges. And so I'm going to pose this question to both of you. What do you see right now as the biggest challenges to really incorporating abolitionist principles and anti-criminalization work into public health?
Do you want to go first, Amber?
Sure. So many challenges, y'all. So many challenges. So a few things that came to mind. One, I think this like specific kind of burnout that is happening in public health and beyond, but I think that it's not only that the work has been intense and prolonged, but I think that there's this certain kind of like, I've heard it described as moral injury. There's a certain kind of like spiritual depletion and like a connection to purpose and an understanding of the ways that our work matters and makes a difference. These sorts of things that I think spiritually, emotionally, socially, psychologically, all the adverbs have really depleted energy is real. And how hard the fight so many of us have engaged in have not we've not seen the results that we want yet. I think that that's just an immense challenge. Another is, and I'm going to drop a link to a panel I listened to recently that was really powerful. I think that we have not, like, I don't think that we're sufficiently skilled up on how to hold conflict among folks who share aligned visions or values. And so I'll drop a link to this. This panel recording is only going to be available till March 25th. I highly recommend watching it, watching and or listening to it. I find myself thinking about a couple of gems over and over. One of the speakers on the panel, I think it was Sandolo, talked about the particular type of like charged, excited, but kind of unstable energy that can come when entering into a space or place where it's like, oh, I've been like in this, horrible work environment before. And now I'm in the place where like social justice are the values, health equity is the value. And then when you like come to realize there are humans in that place who are going to make mistakes, and there's baggage institutionally. The organization might do you wrong in big or small ways. And the particular kind of pain and outrage and betrayal that can come after that in the spaces where we believe there's alignment. I think that there's so much work and skilling up and honest conversation that needs to happen about conflict that feels really important. And then back to the takeaway I shared at the beginning of like roles and capacities, I think and maybe this actually kind of goes to what I'm also excited about, but I'll drop a link to a very short resource, like deliberately did not make it a 57-page research report. It's a 4-page resource made in the style of critical resistance's resources that outline what abolitionist steps versus reformist steps can look like. And so we made this about using the 10 essential public health services. What are meaningful things that people can do in public health within the 10 essential public health services framework to either dismantle the systems of criminalization and or to build up alternative non-carceral systems of safety, accountability, including for drug users and beyond. So I'll drop a link to that in there, but I think doing some of that work to figure out what the role and capacity really is both a challenge and an opportunity.
Amber, I love how you're always so concrete and specific and practical, and I am not, I'm afraid, but so thank you for that answer, which is going to be much more helpful than mine about what I find challenging. I think one of the biggest challenges that I see is that we're a society and a culture that really loves to punish and scapegoat people. And I feel like we have this sort of cultural bent towards criminalization, and that we use stigmatized groups and criminalization to really avoid looking at real structural inequities that drive public health harms, right? So it's this individualizing social problems and blaming individuals for those problems that somehow they have failed, rather than really looking at root causes. And why don't we look at root causes? I think because it means we have to get real about the ways that racism and white supremacy and capitalism have created those inequities and captured those systems. So I think we really have to get real about uprooting these drug war and other punitive logics in these so-called helping systems, right? And we need to support more community-based efforts for mutual aid and care, because I think some of our state systems are so entrenched in this kind of thinking that it may actually be hard to rescue them. And then, ultimately what I think we need to do is really listen to and be led by those who are directly impacted. Those are the folks that have the solutions and know the way out. I think working in collaboration with sort of technical experts. So I'm gonna leave that there. I hope that wasn't too depressing.
No, I think, we can't name the issues. We can't solve the issues until we name them. And, I think, Amber, one of the things that is that you were talking about how we get into these spaces and they're really, really challenging. Absolutely. Like we figured out, we can talk about our values, we can talk about that end goal, and we haven't figured out how to do that incremental work in a way that feels that we're sure about. And I feel like what you were naming is so deeply tied into the conversation that we're having about the war on drugs logic, the punitive logic. Jules, what you were saying about being so tied to punishment and carcerality that, we can, if we abolish the police tomorrow, if we abolish the prison system tomorrow, we would still have to do that internal work about understanding how we approach conflict with each other, what we do when we want to maintain relationships but heal our wounds. And I feel like so much of what you guys are saying today about how we need to divest from the system of carcerality, yes, it's about health, yes, it's about our systems, and I feel like everything you just said is so also tied into recognizing the ways that these assumptions are really insidious. And that it is the internalized piece as well. And so we're going to open it up in a minute for the last 15 minutes for Q&A. But I have my favorite question to ask to any panel to give y'all some time. Thank you so much for the questions y'all have put in the chat. We did not miss them. We're going to come back to them first. But to give folks some time to put additional questions in there. What is happening in the field that is getting you two most excited right now for this work?
I can go first if you want. I am actually really excited about the pendulum swinging back towards community-driven research and policies, and in particular, I'm really excited about the drug user organizing I see going on, and seeing more and more people who use drugs being actively engaged, not just in research, but also in policy development and advocacy. So I'm super excited about that. I'm very excited about all the movements I see towards abolition and mutual aid and the creativity and visioning that's going on around different systems and structures for helping people. I'm super excited about that. And then I think the last thing, and I think, this webinar series is part of this, is this kind of growing understanding of trying to get out of our silos and working across systems, and understanding, right, that the movements for change share a lot of the same root causes and root problems, and that when we come together and talk about things like criminalization, whether it's of sex work or people who use drugs, or all the many manifestations of it, not only are we building shared power, we're also building a shared understanding of these, what I think are sort of fundamental upstream causes of a host of problems. And that makes me excited, because I think once we identify those, we can start to identify real solutions.
Plus one to all of that. So many things are getting me excited or hopeful, or kind of giving me a sense of purpose and connection to this. One is I recently worked with an amazing artist and cultural strategist, Evan Bissell, on exploring how we might use arts and culture strategies in the work to advance abolition. And that was delightful and wonderful for so many reasons. One of the exercises that I would offer here, that, if this is something of interest, like you could take this back to your team, to your department, to whoever, is to do a letter writing exercise, sort of inspired by the idea of like cops in our heads, cop in our hearts, exactly to what you were just sort of alluding to, Kate. I think of this being attributed to Paula X. Rojas, who was part of the Insight group. And so there's an exercise basically to like write a letter to the cop in your head, write a letter to the cop in your heart. Are those two different people, are they not? And like it as a way to kind of like be in dialogue with like what's going on inside. But so generally just thinking about arts and culture work more has been really exciting to me. Another is, you know, very much inspired by folks like Adrienne Murray Brown. I think that like her idea about like the small is all, and also like moving at the speed of trust. Like I actually just think after a very intensely fast few years, I'm really liking slowing things down and like finding spaciousness and just like recognizing that like we cannot make things go faster than they can go. And so like stopping fighting that, and there's like a sort of like anti-capitalist ethos to that too, that like just feels really good and right to me right now. And lastly, as on like the small is all bit, I think finding concrete, even if very micro ways to practice some of this work, be it in a relationship, which, you know, I don't mean romantic relationship, just like a friendship, or in a community, or in an organization, or whatever, and like actually really trying something on and practicing and celebrating the wins when they happen, just feels really re-energizing. And a word that Evan sort of offered was like, it's a hydrating experience.
Oh, I love that framework. And the way that both of what you guys talked about is so related to the goals of shifting those dynamics, of uplifting community, of recognizing how those power dynamics are playing out. And I really appreciate centering in that as what is getting you excited. And Amber, what you said resonated so much about celebrating the tiny wins. I think that is something that also really harms us when we are like, no, we have these values and we'll celebrate when racism and violent capitalism and carcerality don't exist. And we're just gonna slog through till then. And figuring out what to celebrate, being process oriented, recognizing that every single step is meaningful along the way, I think is the only thing that can energize us and keep us going, keep us hydrated, if you will. So moving to the questions that were put in the chat, please continue to put more questions in the chat for these two incredible, brilliant panelists. But from the first one, this was coming from a harm reduction service perspective, which uses the we. So think about that when in that terminology. And it says, we often hear from our law enforcement, court system, elected leaders, prosecutors' office, et cetera, that what we are doing isn't working. These are folks who still very much back the war on drugs philosophy. How do you suggest we can most effectively help them consider that they may need to also consider that their criminalization of the folks we serve is a huge part of what is not working? That is a fantastic question that I'm absolutely certain more than one person in this conversation has, and would love to hear your thoughts.
I can jump in first. A few things. One is, again, like someone needs to deal with the folks who are in that sort of space right now. It doesn't necessarily have to be you. And so I don't say that to be like, you deal with that, you deal with that, you deal with that. No one's dealing with them way. But I think maybe relatedly, a second point is like, I have tried to get very, very deliberate about who I'm working to shift and transform and who I'm just not going to deal with, right? Like I have finite resources, I have finite energy, and I really try not to sink so much time, energy, resources into people who are determined to misunderstand us. And so understanding when someone's coming with a genuine curiosity, with a genuine openness, and when someone's asking questions, being antagonistic to be adversarial, that's not a productive place to start. And so I'm not going to enter into that, right? And so I think if the folks that you're hearing this from directly, if you have a sense either that it is your role that you need to be doing some of that pushing, and or that there's some openness, and so you feel a desire to do some pushing and opening, I in some cases, most cases, try to get people to understanding like try to open them up to believing that other non-carceral approaches, harm reduction approaches, are also valid. Like, you know, a sentence I will often find myself saying is like, look, I'm not here to yell at the people who have lost their loved ones to police violence or jails or incarceration about not pursuing prosecution, because that's not abolitionist. I never would tell people that that's not for them, but I hold a politic around that. And I think saying, like, for the people who aren't going to, for the violence survivors, for the whomever who aren't going to go to the police, don't they deserve options too? Don't they deserve options for accountability, safety, and consequences that don't rely on carceral systems? And shouldn't we be thinking about building up multiple solutions to address these really difficult issues? And so I think that instead of trying to get them from like abolition is nonsense and only carceral approaches make sense to abolition is the way, getting to a lily pad in between where there's an openness to non-carceral solutions feels sometimes like a more viable place to get people to along the way.
Well, that's such a good answer. I don't have much to add to that. I would just say on the specific question of, you know, the failure of harm reduction, and especially as we've seen sort of these rising narratives around public disorder and, you know, crime rising. I think what I want to say about that is a couple of things. One is when it comes to drug policy specifically, it is not hard to point out the failure of the war on drugs, right? Like that's not even really contested anymore. And it's like, well, do you want to keep doing the thing we're doing that has not only not worked in terms of if its purported purpose was to control the use of drugs, but also like created so much harm to so many people, right? There's that piece. And then there's like just the fiscal cost of it, which is fucking disastrous. So there's that. There's always pointing to the harm, the failed approaches of the past, and most people understand that and want to try something different and new. The thing about harm reduction is that it really hasn't had its moment yet. I mean, I know it's been around for decades, but it has never come close to being scaled the way that we've scaled policing and law enforcement. And when you look at the kind of spending that we're doing on the militarization of police and the drug war, and you compare that to what we're spending on harm reduction, it's a drop in the bucket, you know? So, you know, I get a little enraged and apparently speechless when that argument is made, because we've barely begun to invest in harm reduction and at the scale that we need to for it to have to make a real difference. And then, you know, I just want to sort of echo what Amber was saying for the need for sort of multiple solutions. Like it's a both and, you know, and in terms of like incremental versus visionary reform, like this is a tension that we face in our work all of the time. And, you know, we need it all. What I would say about incremental reform is you have to be incredibly cautious that you are not compromising in ways that are going to ultimately undercut your larger vision, and you cannot compromise on that. And sometimes you have to like make really challenging decisions about holding back for something that's going to be more liberatory ultimately for more people. And we've seen the way, for instance, that like so-called like race neutral policies are not race neutral, right? They actually are often increase racial disparities. So that's just one example of like just needing to be incredibly thoughtful and cautious about the kinds of compromises we make in the policymaking process, which frankly is inevitable. That's how policy is made. It is by definition incremental.
Those are such fantastic points. And I think, you know, in that conversation, and just to add from my experience at Reframe, all of us have backgrounds around advocacy and criminalization. And I think one of the other things is, at least I know that for a long time, I was taking a lot of those things at face value, and especially when they were told to me from, you know, politicians and elected folks. And even coming from an ethic of abolition, I always find people in law enforcement that understand that it's not working either, and they're upset about it. And very often they're in positions where they can't tell the chief of police, they can't have an honest conversation with someone, but they might have an honest conversation with someone outside of that setting, and they might be able to have a conversation where if I said it, no one would listen. But if I have someone who is in law enforcement, who understands, who sees that day to day, and can speak to someone in law enforcement with an air of authority that I'll never have with them, there's a lot more people than I ever anticipated who were like, I shouldn't be responding to this. I respond to this because I'm told to and I have to. I'm the wrong person and I'm really scared that I'm doing harm. And that I have seen go from frontline officers who are stressed out and traumatized watching people have mental and medical health crises, all the way up to folks that are much more in, intense detective services, much more on a different scale, who also are very frustrated with how things are right now.
Yeah, we're hearing that from mandated reporters too, who are saying like, I do not want to report suspected or even real substance use when I know that it is not impacting, the safety and well-being of the children, and yet I am required to by the systems I work in, and so, those are very difficult positions people are put in. And I think, Amber, you have such good suggestions about how people can sort of wrestle with those kinds of questions and really think about what, sort of small steps they can take, while we're waiting for the new vision of a better world. So I think that's really important, because a lot of people are working in these systems and they see the punitive frameworks and the criminalization, and they don't want to be a part of it. And yet this, what Weber called the iron cage of bureaucracy really pushes down on them.
And so we are running right up to time, and I apologize for the questions that didn't make it into the conversation. But also the discussion on the thread has been fantastic. And so first, I just want to thank the both of you, Amber and Jules. You guys are absolutely brilliant, and I've really appreciated how much you brought to this conversation, both in terms of your brilliance and also your intentionality around community and who you lift up and the way that you do it, the way that you approach your partners, and the humility that both of you bring in knowing that we are all on this process of learning and unlearning, and the fact that you guys are willing to share that process with us, it is genuinely an honor. So thank you both so much for your time today, and everything that you shared. And now I'm going to hand it back over to Alika.
Thank you, Kate and Amber and Jules. It's been so great to hear you guys today in this conversation, and just super thankful for being here with us. Just for some follow-up, we will send out the webinar recording within the next week, and as well as send out the links in the chat with all the wonderful resources shared. And we'll be doing a second follow-up webinar in the next 3 weeks, I believe, on March or April 6th. I can send the link in the chat for the registration for that webinar, but it's going to be a little more, we're going to be talking about anti-criminal strategies and how to see them more in action. So sending the link there. And thank you all so much for coming here today.
Thank you. That was so fun.
Thanks.
Bye, everyone.
Thank you all.